Welcome to Acting for Public Health, Challenges and Opportunities in Legislatures and the Courts. My name is Casey Deems, and I'll be running today's web forum along with my colleague, Jeff Bornstein. This web forum is sponsored by the Leadership Academy for the Public's Health, a program of the PHI Center for Health Leadership and Impact, and produced by Dialogue for Health. Next slide, please. A little bit about who the PHI Center for Health Leadership and Impact is. Our mission is to help you in building healthy communities and creating sustainable impact at scale. We do this through a focus on strategy, partnerships, coalitions, action, and data. Next slide, please. So at this point, I'd like to introduce the moderator of today's event, Sabrina Adler. Sabrina is the Vice President of Law at ChangeLab Solutions. She works primarily on legal and policy issues related to preemption and good governance, the commercial determinants of health, and healthy children and families. She has co-authored publications and presented on many issues at the intersection of law and public health, including sugary drink policies, food policy, preemption, and health equity. Welcome, Sabrina.
Thanks, Casey. We can go to the next slide. And hello, everyone. I am going to be moderating today, and I will start out just quickly for those who aren't familiar with ChangeLab Solutions, a quick overview of who we are. We are a nonpartisan nonprofit organization that uses the tools of law and policy to advance health equity. So we partner with communities all around the country to improve health and opportunity by changing harmful laws, policies, and systems. I am an attorney, but we have an interdisciplinary team that works with community organizations, governments, local institutions, and others to design and implement equitable and practical policy solutions to complex health challenges. So on behalf of ChangeLab Solutions and all the Act for Public Health partner organizations, who I'll introduce further in a minute, I want to welcome you and thank you all for joining us today to discuss challenges and opportunities in the shifting landscape of public health authority. Next slide, please. Here's what we're going to cover during today's session. So I'm going to start with just a quick background and intro to how we got to where we are and the Act for Public Health initiative, so why we're here. Then I will introduce all three of our speakers and hand it over to them. So first we'll hear a summary of some of the legislative tracking trends and what's been happening in legislatures around the country from Katie Moran McCabe at the Center for Public Health Law Research at Temple. Then we will learn more about what's been happening in the courts from Wendy Parmet at the Public Health Law Watch. And then finally, we'll get some insights on investments and innovation. So thinking about where the trends are going in some exciting directions from Darlene Huang-Briggs at the Network for Public Health Law. Next slide, please. First, to set the stage, this won't be news to anyone on this webinar, I would imagine, but in 2020, as the pandemic started to unfold, the public health systems and structures that have been in place really for decades and largely have operated behind the scenes to keep the public safe and healthy pretty quickly took center stage. And while many people, most in fact, probably supported the measures that were put into place, there was definitely a vocal contingency, both of the general public and of policymakers who took issue with what those of us who work in this space would consider even the most basic of public health activities, like masking, social distancing, vaccination, and more. And as I'm sure you all saw, that contingency caught the attention, at least in some spaces, of the media and controlled some of the messaging around what was going on. And that also quickly was accompanied by, or in some cases probably translated into, a variety of actions. So we saw protests and attacks on public health officials, and what we're going to hone in on more today, in legislatures and in governors' offices, we saw policy changes that in various ways sought to, at times, undermine the power of those who were most equipped through their expertise and training to protect the public's health. And so for those who those of us, again, who work in this field, all of a sudden we saw public health become very intensely politicized. And some of these decades old structures being dismantled in some states in particular through rushed and uninformed votes that often were more knee-jerk reactions to what some politicians saw as infringements on personal liberty or otherwise sort of improper uses of government authority, even when those things were in service of the common good and attempting to bring the pandemic under control. We also saw, and we'll hear more about, a mixed bag in the courts. So while many judges upheld the authority of public health officials to take various measures to combat COVID-19, others began to veer from longstanding precedent and find what they saw as overreach and therefore strike down actions based on rationales that sometimes were specific to the issue at hand, but often could have implications for the future of public health more broadly. And all of that is what we're going to dive into more today. Next slide. So as all this started to happen, at first in a somewhat ad hoc way, those of us who work in public health law specifically started to dive into all these various issues that were popping up. So we were tracking and analyzing bills and court cases, talking to the press and the media, writing op-eds, providing technical assistance to communities and policymakers. We came up with different typologies for the various types of legislative actions we were seeing. So everything from preemption of local public health authority to shifting which branch of government had the authority to act, looking at whether different changes were specific to COVID or specific to emergencies or broader than that, and so on. And eventually that led to the formation of a more coordinated effort among the organizations that you see on this slide and that are here with us today. And we've called that effort Act for Public Health. Act for Public Health is an initiative which is supported by the Robert Wood Johnson Foundation, among others, and exists to evaluate and work with the field to respond to what's been happening to public health authority in the wake of the backlash to the public health COVID response. Next slide. So what have we been doing? You're going to hear more in detail about some of these pieces in a minute, but we've been working with the field in all the various ways you can see on this slide for the past 2+ years now. We are dedicated to using legal tools and processes to help shape a fairer public health system more generally. And our connections to folks in the field, like those of you on this webinar, are really fundamental to how we do this work and what we do with it. So you'll see on this slide, there's a QR code. You can also go to our website. The link will be there in a minute, and we can pop it in the chat. But we would welcome those of you who aren't already part of our email list to join and connect with us in that way. Next slide, please. So a few examples of specific things that we've worked on and produced that might be of interest. During our first few years of this work together across organizations, we've put together a number of resources. So what you can see on this slide is some fact sheets that summarize at a very high level some of the trends that you'll hear more about today, also what the practical health equity impacts have been in our communities of some of these changes, thinking through why and how we might grow partnerships and find new ways to address some of these shifts directly. Next slide, please. So because you're going to hear directly from the researchers, I'm not going to go into detail about these trends that you can see here, though we do have resources that discuss them. But in general, what we have seen is a move away from decisions being made in the places where there's local connection, where decision making can be quickly responsive to public health expertise and what those experts, which may include some of you all, are seeing in your communities. Next slide. Another thing that we've gotten a lot of questions and inquiries about is the ability of the public health community to be involved in advocacy activities. And sometimes that is specifically related to rules around lobbying and what is and what isn't permitted. Often it's just thinking about advocacy more broadly and what that can mean even outside of the context of lobbying, and recognizing how powerful the public health voice can be, and how centering it and ensuring that it's heard in the policymaking process is so important. We've also put together some resources on those issues. So what you see on this slide is, and you can find on the ChangeLab website or linked from the Act for Public Health website, is a training specifically around public health advocacy, thinking through it. Part of it is parsing out what's lobbying and what's not, and what may not be permissible in certain contexts, but part of it is also just talking about the world of advocacy in this space more broadly. So I encourage you to check that out. Next slide. Another piece that we have had the opportunity to dive into a little bit, which has come up a lot also in the requests that we get from folks and conversations that we have, is that just communications and messaging. So we were fortunate to be able to partner with the Berkeley Media Studies Group and their partner Real Language to create and record, which you can also access at the link on this slide, a webinar talking about framing and how to talk about public health in a way that motivates support and action rather than sort of fear and backlash. Next slide. And the broader communications work also was put into this report, which you can see here, also available on the website, talking about all of the various things that the folks at Real Language and Berkeley Media Studies Group found in their work to consider effective ways of talking about championing public health in the current environment. Next slide, please. So you can see, if you dive into some of those communications resources, some of the tips that they have, you will also see their recommendations and thoughts on messaging integrated into Act for Public Health materials and resources. So this is an example from the FAQ section on the Act for Public Health website. And one of the sort of main points that Berkeley Media Studies Group makes is to really break down jargon and tie things back to root causes. And so that is infused throughout the work that we do as a group. Next slide, please. So that's a pretty high level overview of what we have been doing and sort of how we got to this place where we are working together on these issues over the last few years. Again, I'll encourage folks to check out the website, the link for which I think Darlene put in the chat and also appears here on this slide. Join our emailing list and reach out to us at any point with any questions or thoughts about this work. Next slide. So now I'm going to introduce all three of our speakers for today so they can just run from one to the other. So first, we'll have Katie Moran McCabe, who is a lead law and policy analyst at the Center for Public Health Law Research at Temple University's Beasley School of Law. Katie conducts legal research and leads projects on a variety of policy areas related to public health. She co-leads the Center's Public Health Authority legislative tracking work, which she'll be talking about today, part of the Act for Public Health initiative. She also has led several housing-related projects for the Center, as well as the development of the Sentinel Surveillance of Emerging Laws and Policies legal mapping method. Next slide. And we will have Wendy Parmet, who's the George and Kathleen Waters Matthews Distinguished Professor of Law and Professor of Public Policy and Urban Affairs at Northeastern University, where she's also the faculty director of the Center on Health Policy and the Law. Wendy's an associate editor for the American Journal of Public Health, and her most recent book is Constitutional Contagion, COVID, the Courts, and Public Health. So very relevant to today's topic. Next slide. And then finally, we'll have Darlene Huang-Briggs, who is the Network for Public Health Law's Deputy Director for this Act for Public Health initiative. She provides collaborative leadership to Act for Public Health, which is this partnership that I just described. Darlene began her career at a local county health department and has held law and policy positions at the US FDA, Public Health Law Center, the O'Neill Institute at Georgetown University, and the Campaign for Tobacco-Free Kids. Her work over the years with interdisciplinary teams, including consulting on regulatory science issues, has been centered around designing, enacting, and implementing equitable public health laws and policies. So with that, I will hand it over to Katie to dive into the legislative tracking. Thank you.
Great, thanks Sabrina. Hi everyone, thank you all for joining today. So as Sabrina mentioned, I'm going to talk about some of the legislative tracking work that we've done. Next slide, please. And I wanted to mention, in addition to the Act for Public Health collaborators, we have some other partners in the legislative tracking work, the Association of State and Territorial Health Officials and the Local Solutions Support Center. Next slide. So I want to start just by giving an overview from the first year of our project, where we were tracking state bills that were introduced from January 1st, 2021 through May 20th, 2022, that addressed public health authority in some way. Next slide. So for that initial time frame, we tracked bills on 6 topics related to public health emergency authority, and we created a legal data set for each topic to identify the key elements of the legislation. So the topics are listed here in red on this slide. They are limits on public health emergency authority, the reallocation of public health authority, bills strengthening public health, state limits on the enforcement of federal law, regulation of public health measures, and public health preemption. So this slide shows the homepage for the data sets, where you can access each of them on lawatlas.org. Next slide, please. So there were 1,531 bills introduced in that time frame that we tracked that touched on one or more of those topics that I just mentioned. And 191 of those bills were enacted into law in 43 states and DC. Next slide. So here, the smaller pie charts that you can see on the right side of the slide show the breakdown of the bills that were introduced and the percentage enacted for each topic. So as you can see that the topic with the most number of bills introduced by far was emergency measures regulation. So these are bills that address the specific use of a specific public health measure. Next slide. So sort of in the middle of this slide here, you can see the list of the specific public health measures that were regulated. So vaccine measures, mask measures, places of worship, business measures, school measures, and testing. So this slide shows the progression of those types of bills that were introduced last year. So that red line at the top of the graph represents the vaccine-related bills. You can see that was by far the most commonly regulated type of public health measure. And then if you look at the table on the right, you can see the changes in the number of bills introduced on each measure. So for example, for vaccine measures, the 501 represents the number of bills that were introduced between January 1st, 2021 and January 1st, 2022. And then as of May 20th of 2022, that number of vaccine-related bills grew to 691. And then you can see the similar numbers for each of those measures going down the list there. Next slide. So this map shows the states that enacted one or more bills related to vaccines as of May 20th of last year. So there were 66 bills enacted in those highlighted states. The states that are in yellow enacted one bill, and the states that are in purple enacted multiple bills. And some of these bills supported the use of vaccine measures. So there's some examples here. You can see New York Senate Bill 4807 that authorized pharmacists to administer immunizations recommended by CDC. And then many of these bills restricted use of vaccine measures. There's Utah House Bill 63 that requires employers to provide an exemption to vaccine requirements for people who've had a previous COVID-19 infection. And then another example of a restrictive bill is the South Carolina House Bill 3126 that prohibited vaccine mandates for state employees and school children. Next slide, please. So next, I just wanted to go over the bills that limit public health authority related to emergency orders. So this was another data set in which we tracked limits to a governor's authority, limits on state health official authority, and limits on local health official authority as it relates to emergency orders. So this includes things like restrictions on the issuance of an emergency order, or limits on the duration of an emergency order, restricting the scope or the substance of an order, and also provisions that explicitly allow for termination of an order by the legislature. So this slide shows the progression of the bills introduced on this topic. And again, if you look at that table on the right, you can see the changes in the number of bills introduced, limiting the authority of each of those groups. So as of January 1st, 2022, there had been 308 bills introduced that would limit a governor's authority. And then as of May 20th, the number of bills grew to 431. And then you can see going down there the number of bills for the state health official authority and local health official authority as well. Next slide. So again, as of May 20th last year, there were 65 bills enacted into law that limited public health authority. And here we just have some examples of those enacted bills. There was Utah Senate Bill 195 that limits emergency declarations issued by a governor or state or local health department by limiting the duration of an emergency declaration, restricting when an order can be reissued, and also allowing the legislature to terminate an emergency declaration. Another example is New Hampshire House Bill 440 that prohibited the suspension of civil liberties during a state of emergency. So this just gives you a couple of examples of the types of bills that we saw on this topic. Next slide, please. Okay, so that was the first year, the first phase of our project. And now I want to talk about what we're currently working on. We're now tracking slightly different legislation. So next slide, please. So this year we've been tracking the same types of bills that we were tracking initially, but the topics we've combined into one data set instead of having 6 separate data sets. And this data set only includes bills that have been enacted. And then we're also tracking some select legislation around immunizations, which I will talk about shortly. Next slide, please. So this is the homepage for the data set that we released this year, capturing those enacted laws on the 6 topics that we've been tracking. So it picks up date-wise where the initial 6 left off. So those data sets went through May 20th of 2022. This data set includes legislation enacted from May 21st of 2022 through May 22nd of this year. Next slide. So this map shows the states that have enacted one or more bills addressing public health authority to respond to emergencies during that time frame. Again, May 21st of last year through May 22nd of this year. And there were 37 bills enacted in those highlighted states. So in 17 states and DC. Next slide, please. And on this table, you can see the types of laws that were enacted during this time frame. So you can see laws limiting public health measures, again, were the most common. So there were 17 of those. And within that category, vaccine measures were the specific measure that was most commonly regulated, with 15 of those laws limiting vaccine measures in some way. But then you can also see laws expanding public health measures were the next most common. So there were 14 of those, 8 of which related to vaccine measures. So some states working to restrict vaccine measures, but then also states working to support use of those measures. Next slide. And here are just a few examples of these enacted bills. These relate to preemption of local authority. So Utah House Bill 131 prohibits an employer or governmental entity from requiring people to receive a vaccination. And just noting that this particular bill is not specific to COVID-19 vaccinations. There's also New Hampshire House Bill 1495 that prohibits state and political subdivisions from requiring a business to require vaccinations or to check for vaccination status. And then West Virginia Senate Bill 128 prohibits health officials at the municipal, county, or state level from taking any enforcement action that's not explicitly authorized by statute or by a governor's executive order, even in an emergency. Next slide, please. So I mentioned we are we're working on another data set that is still being finalized. It's not yet published, but coming soon, so stay tuned for that. This is a data set that we created to track select vaccine-related bills that have been introduced this year. So it's not limited to enacted bills. It includes bills at any state of the legislative process and includes the types of bills that are listed here. So those that add or remove school entry vaccination requirements, those that limit or expand non-medical exemptions for vaccination requirements, bills that reallocate the authority from health agencies to make determinations about what vaccine requirements are, and then bills that expand scope of practice for vaccine administration. So we expect to be releasing this data set soon. So again, stay tuned. Next slide, please. I just wanted to give you sort of a preview of some of the preliminary data that we've seen in this area. So this table shows the breakdown of the types of bills, how many were introduced, how many were enacted. So you can see the most common type of bill introduced were those removing school entry vaccination requirements. There were 79 of those. But also want to highlight there were, a lot of bills introduced that would expand the scope of practice for who can administer vaccines. So there were 70 of those, 8 of which were enacted. Okay, next slide, please. So as I mentioned, you can find the data sets on lawatlas.org. I can put the links in the chat as well, or you can scan these QR codes. So encourage you to take a look if you are interested in learning more. Next slide. And here's my email address if you are interested in following up. That would be great. And that's it for me. Thank you so much. I will pass it over to Wendy. Thank you.
Thank you so much. Sorry, I was muted. Wait. So thank you so much. Next slide. I want to thank Change Lab Solutions and Robert Wood Johnson Foundation, which have supported our project tracking litigation during the COVID pandemic, and now looking more generally at public health authorities litigation. I also want to thank all of the partners in the Act for Public Health partnership. Next slide. So my talk is based on several different studies that I and my team have done over the past several years. We began by tracking cases that talked about Jacobson versus Massachusetts, which is obviously one of the foundational public health law cases. Then looked at really all public health authority decisions from March 2020 at the beginning of the pandemic through 2022. And now continuing to look at cases, including particularly vaccine cases. The QR code takes you to an article that my colleague Faith Colleague and I published last winter in the American Journal of Public Health on our study from March 20 of decisions from March 2020 to July 1st. 2022. It will give you more detail if you're interested, and it will also lays out our methodology that we are continuing to apply. Next slide. So give a very brief overview through 2022, and I'm stopping there because we have somewhat narrowed and altered the search criteria since then. We looked at over 1,200. We've compiled over 1,200 decisions in state and federal courts. They range from, not surprisingly, a wide range of kinds of legal claims. And indeed, sort of almost any legal claim you can imagine has been brought. The common categories that we saw were due process claims. These include procedural and substantive due process, equal protection claims, and most of these had to do with things like closing one kind of business and not another. Religious liberty and free exercise claims being brought under the Free Exercise Clause of the First Amendment, and then scope of authority cases that usually combine statutory questions and constitutional issues, and ask, and these are really the core authority cases, did the official act within the scope of their legal authority in issuing the orders that they did. Next slide. So the litigation and the judicial decisions that we've been tracking have really followed the course and contours of the government's response to COVID-19. And it was interesting to see Katie's slides because they really sort of follow the same path or direction that she was showing in terms of the legislation. So in the early months of the COVID-19 pandemic, states and local governments issued a wide range of what we call social distancing measures. These are laws and orders that were designed to slow the transmission of COVID-19 by reducing the size of gatherings, closing businesses, in some cases restricting travel. These were not individual isolation and quarantine orders as much as really, business closings and all those kinds of things that we saw in the early months of the pandemic. As those orders were lifted, as the weeks and months went by in 2020, what we started to see was more litigation about mask mandates. And many jurisdictions were lifting the social distancing orders, but putting mask mandates into place. So people could now go out to stores and restaurants and things more freely, but they had to wear a mask. And so there were challenges. And then in 2021, once the vaccines became widely available, we started to get vaccine mandate cases challenging the mandates. Most of these were brought by public employees, healthcare workers, and students at state colleges. Next slide. So some very large, high level kinds of conclusions that we found. And I want to really underscore this one. Most judicial decisions came out in favor of public health authority. To be clear, that doesn't mean that the court ruled that what the public health official did was legal, but they refused to grant the relief requested by the plaintiffs. They may have found that the plaintiff didn't make out a sufficient case, or they may have dismissed the case, okay? Plaintiffs were more likely to win in administrative procedure cases. Many of these were cases that said challenge the use of orders as opposed to regulations, or the processes, the administrative processes that officials used. Plaintiffs also did relatively well when they raised religious liberty, free exercise challenges. And I'm going to talk more about those in a moment. Less well, but there was still some success in due process cases. There were also some very significant rulings in favor of the plaintiffs. In particular, the US Supreme Court blocked CDC's eviction moratorium on scope of authority grounds. Likewise, the Supreme Court blocked OSHA's vaccine mandate or test and mask mandate for large employers. And a federal district judge in Florida blocked CDC's transportation mask mandate. That case, by the way, has since been vacated because it's moot. But no higher court has upheld CDC's authority. Next slide, please. So just to give a little bit of flavor, because one of the things we've been talking about is really sort of how the court's views and attitudes and approaches to COVID-19 changed, and to the exercise of public health authority changed during the course of the pandemic. Early on in the spring of 2020, as all of these orders were issued, closing schools, limiting the number of people who could appear at worship, closing some kinds of business establishments, movie theaters, live theaters, et cetera, what we saw by and large was courts being very deferential to health authorities, not very sympathetic to the challengers, lots of decisions saying this is a public health emergency, and a lot of decisions relying on Jacobson versus Massachusetts, which I mentioned a few minutes ago. And for those of you not familiar with Jacobson, it really was a foundational public health law case for a very long time. It upheld a vaccine mandate during a smallpox outbreak in Cambridge, Massachusetts. And the court emphasized there that the state can take reasonable actions to protect the public's health and the need to defer to health officials. So in early 2020, we saw lots of courts relying on Jacobson. And in May of 2020, the US Supreme Court, in its first COVID decision from the so-called shadow docket, refused to block a California law restricting the number of people who could engage in in-person religious worship. There was no majority decision. This is a shadow docket case. That means it's from the court's emergency docket. There was no full argument, no oral arguments in this case. But Chief Justice Roberts wrote a very important concurring decision citing to Jacobson and saying that the Constitution principally entrusts health decisions to politically accountable officials. But interestingly, Justice Kavanaugh wrote a dissent that two other justices agreed with, saying that he thought that the state had violated the First Amendment by treating religious worship less favorably than some other secular activities. 2 months later, a similar case comes up, this one from Nevada. This time, the majority does not issue a decision. This is the Calvary Chapel Dayton Valley versus Sisolak case. But this time, Justice Alito writes a dissent that says Jacobson simply is not relevant in a religious liberty case. Next slide. A few months go by, and Justice Ginsburg dies and is replaced by Justice Amy Coney Barrett on the Supreme Court. And what I want to do, without getting into the weeds of all the cases, is emphasize just how dramatic a change that brought. Because the other two cases I was just talking about were decided 5-4. Now it flips, and we now have 5 justices who are supportive of challenges to COVID-related orders, particularly relating as they apply to worship. And that first became apparent on Thanksgiving Eve in 2020 in Roman Catholic Diocese versus Cuomo. And what's remarkable about that case, again, without getting into the weeds so much, is that the majority opinion, also from the shadow docket, provided absolutely no deference to health officials. In fact, the majority seemed really remarkably uninterested in public health evidence. In addition, the majority really suggested that it would be offered an analysis that it would be very, very hard for public health orders to ever survive. Then in April of 2021, after several other decisions relying on Roman Catholic Diocese versus Cuomo blocking orders, the Supreme Court enjoined a California law that limited the number of people who could meet in a private home. And the court did that for the plaintiffs, because the plaintiffs said they wanted to meet in the private home for Bible study, and noted that the state did not have the same capacity limits for train stations and retail shops. According to the plaintiffs and the majority, by treating Bible study in a private home less favorably than train stations or retail stores, supermarkets, the court had had effectively treated religion unfairly in violation of the First Amendment. What I think is really important to note is that the California order did not mention Bible study. It was just a general limit on the number of people who could appear. And so it led to it created a approach by the Supreme Court that effectively gives claimants who want to challenge health laws on religious liberty grounds what is known as most favored nation status. As long as they can point to any secular activity that might be treated more better, that they can say is comparable, the court will say that the state has to basically create a carve out for the religious plaintiffs. Then in June of 2021, in a case that was not a COVID case, Fulton versus City of Philadelphia, the court also said that if a law has an exemption, and if there's any discretion given to the official on whether or not to give the exemption, the failure to give an exemption to a religious objector is subject to strict judicial scrutiny. Accordingly, I should note, none of these cases talk about Jacobson. It really has been pushed to the sidelines. Next slide. This approach that I was talking about began to almost immediately to have an important impact on vaccine cases. For well over 100 years, it had been established that vaccine mandates are constitutional and do not have to have religious exemptions. But these cases, Tandem versus and Fulton in particular, really offered a way for those who wanted to challenge vaccine mandates to do so. And there's 2 kinds of challenges. One is if the mandate doesn't have a religious exemption, to say that that's like, that as long as, to say that if any other kind of exemption is out there, right, that there has to be a religious exemption. And the second way is to say if there is a religious exemption and it is denied, that seems to fall under Fulton. And almost immediately we started to get these cases. Early on, several courts rejected this. One important decision that actually went to the Supreme Court, but it refused to hear the case, although there was a heated dissent, was from Maine. Maine had a law requiring healthcare workers to be vaccinated against COVID-19. It did not include a religious exemption. And the plaintiff said, because there was a medical exemption, people who were medically unable to be vaccinated didn't have to be vaccinated. There had to be a religious exemption. Again, that's kind of like saying, well, because you can keep retail stores open, you have to allow unlimited numbers of people in private homes. The First Circuit did not agree with that analysis. They said that medical exemptions are not comparable to religious exemptions. Medical exemptions protect public health. Religious exemptions don't. Again, it went to the Supreme Court. Supreme Court refused to hear the case. Next slide. But, and here's the important but, times have changed. As this litigation has been bubbling up, and there's a lot of it around the country, we're beginning to see a shift. And just recently, last summer, the First Circuit appears to have changed its mind about the Mills case. The court did not overturn its earlier decision. It's in a different procedural posture, so it distinguished it. But the court has now said, the First Circuit has now said that the claim that religious exemptions are comparable to medical exemptions is one that is plausible and a trial should go forward. So the court has refused to dismiss the plaintiff's claim based on the earlier First Circuit case. And so that case is continuing. Next slide. I just want to briefly mention too that there were lots of federal federal vaccine mandates, including for the US military. These provided for religious exemptions, but in many cases, and certainly in the case of the military, exemptions were granted extraordinarily infrequently. And several different courts found that this violated the Religious Freedom Restoration Act, a federal statute that provides and protections for religious liberty against the federal government, and some also found that this violates the First Amendment. And I think one of the extraordinary cases was US Navy SEALs, where the Fifth Circuit at least said that denying a vaccine, an exemption to a vaccine, to a religious exemption for a Navy SEAL was unconstitutional, and actually ordered the Navy to deploy unvaccinated SEALs even into submarines. The Supreme Court limited that injunction, but just how sharply the courts have moved against vaccines, or at least some of the courts. The idea that the Fifth Circuit was going to say that even a submarine that's going out for a long time had to take an unvaccinated SEAL really shows you how far the courts have gone. Next slide. Not surprisingly, these cases have spilled over into childhood vaccines, and we're beginning to see cases in the last couple of months now questioning whether childhood vaccine laws have to have religious exemptions. Most do, but several states did not. And we're seeing some changes. So last summer in Bossage versus Edney, the federal court in Mississippi ruled that Mississippi, which long did not have a religious exemption and actually had the highest rates of childhood vaccines in the country, had to have religious exemptions. And that order has gone into effect. And following the decision I just made in the First Circuit, a federal district court in Maine now, in Fox versus Macon, is allowing a challenge to that state's childhood vaccine law to go forward. In short, I think we're going to see more challenges and more successful challenges to state childhood vaccine laws. Unfortunately, we have good reason to think that this may be followed, right, by more measles and other childhood diseases. Next slide. So very briefly, because I know my time's running out, there are also a lot of challenges to the scope of the authority of health officials, from governors to state secretaries of health to local health boards. We've been seeing many of these around the country. This is just a list of state Supreme Court decisions. Most Supreme Courts affirmed officials' use of public health powers during the pandemic, but 3 state courts held that executive officials had overreached and violated the scope of their authority. These courts read the statutes very narrowly and also suggested that the exercise of authority was unconstitutional. Importantly, interestingly, all of those cases came from so-called purple states. They were Republican legislatures with Republican officials supporting the litigation against the Democratic governors. Next question, slide. At the federal level, this same kind of analysis has been taking place under the guise of what has now become known as the major questions doctrine. As I mentioned before, the Supreme Court ruled that OSHA had overreached and violated its statutory authority in imposing an emergency temporary standard to mandate vaccines or testing and masking in businesses with over 100 employees. But I should note on the same date, the Supreme Court did go the other way in Biden versus Missouri, and it held that CMS actually had authority to impose a mandate on healthcare workers in federally funded healthcare institutions. A major questions doctrine, we can talk more about it. It's complicated, it's uncertain what it means. What is a major question? It seems to be very much up for debate. I also think it's really important to ask what will be the impact of this kind of very narrow statutory construction on state courts. More and more state courts sort of follow the Supreme Court in how it approaches public health powers. Next slide and last slide. So to end, I just want to reaffirm public health in the courts, public health wins most of the time, but not always. And what we are in right now is a world of doctrinal instability. The old verities, there would be deference against health officials, Jacobson is the law, don't have to have exemptions for vaccines. These are now uncertain and have been upended. Also, public health may face special risks under divided government. In other words, the law and politics are not separate. The major questions doctrine, no doubt, poses significant risk to federal orders that relate to health. And it's been applied also in EPA and all kinds of cases. We're seeing it now. So what do health officials have to do? Well, they have to assemble a record demonstrating the necessity of public health measures. That was advice I would have given 4 years ago, but it's really important now. You have to take special care with orders that can affect religious practices. These religious liberty claims are becoming increasingly successful. Remember that mandates can be useful, and certainly there's good evidence as to the efficacy of some mandates, especially like childhood vaccine mandates. But mandates can also backfire, and they can provoke backlash, and they can get you tied up in court, and they can make bad law. So, right, you need to think about when to use them and when not to. And that leaves me with my last takeaway, that persuasion and communication may be more important than legal orders, indeed, especially today, when health officials cannot assume that they had the power that they thought they had 3 years ago. Thanks so much. And now I will turn it over to Darlene.
All right. Thanks, Wendy. And good afternoon or morning if you're on the West Coast, everyone. Thanks for sticking with us. I am Darlene Huang Briggs with the Network for Public Health Law, and my part of the presentation is to help move us towards some potential solutions amidst a challenging backdrop. More specifically, I'll be sharing the types of laws and policies communities have been and can be working on to improve the public's health despite the rollbacks described by my colleagues and experienced firsthand by many health departments. I also just want to take a moment to recognize my network colleague, Jill Krieger. She is the mastermind behind the collection of these bright spots in legal innovations, which have really served as rays of sunshine and reminders that lifting up signs of hope are equally, if not more important to counteracting the challenges. So next slide, please. Before I dive in though, for those of you who are not familiar with the Network for Public Health Law, we are a national nonprofit organization using the tools of law and policy to improve health and health equity. We do that primarily through the provision of legal technical assistance, resource creation, and training to state and local health departments, as well as public health advocates. We have our biannual public health law conference coming up next month, and we'd love to see you in Minneapolis. Next slide, please. Okay, so you've already heard from Sabrina and Katie and Wendy about much of this, and I just want to share 2 reports the network has released describing what has clearly been a coordinated backlash by the American Legislative Exchange Council, or ALEC, and its allies, various allies, to strip, shift, limit, and otherwise roll back public health powers and upset the balance of those powers with the rights of individuals. Next slide, please. And in all honesty, public health is still working toward a coordinated response. These are just some of the institutions that, along with many of you, have been working and mobilizing to push back. And not just to push back, but to also articulate a positive and hopefully unified vision for public health. Our newest innovations report is also a piece of the puzzle, and it's what I'll spend the rest of my time talking about today. The report was inspired by a state health department leader asking 3 related questions. First, what proactive steps are states taking to strengthen public health and public health authority rather than simply reacting to the threats to public health authority? Second, which of those efforts might others consider? And finally, how do we choose between the options? So we worked through these questions and collected examples of primarily state laws and policies, but there are also local examples, and we of course touch on how federal and state law inevitably impacts locals. Our approach to deciding what examples point towards a strong, equitable, and effective public health system was guided by a series of values and goals conversations with various stakeholders over the years. So next slide, please. What we identified are 3 core public health values that we believe we are all working towards to honor and rebalance in this new post-pandemic era. Those values include evidence-based or informed action, which we also recognize includes the need to test new approaches based on emerging evidence, expert opinion, and lived experience, especially among communities most affected. The second value is good governance, which is the ability for governmental public health to be empowered to act quickly and in a flexible and adaptive manner, especially in emergencies, right? But also in a myriad of ways that are accountable and strike the necessary balance between recognizing individual liberties and advancing the common good. The third and overarching value is equity and fairness, which encompasses both the laws and policies that drive equitable outcomes, and that they also provide for more immediate process-oriented changes that demonstrate a commitment to equity and fairness. And at this point, I think it's important to state that we recognize that public health hasn't always ascribed to or emulated the values of equity or fairness, of equity or fairness and good governance, meaning it hasn't always necessarily been a force for good. That's both a major challenge and the real opportunity we have to design and build into the system the safeguards and accountability needed for public health to be trusted by the communities it serves. Next slide, please. Okay, so what are the innovative laws and policies we've collected? They fall into these 6 major categories on the outside of the honeycomb, but they are also interrelated and all contribute to that strong, equitable, effective public health system in the center. Next slide, please. So I'm going to start with examples from the interventions and emergency orders category that Katie hasn't covered, not because they're the most important, but because we've got good concrete examples here that are also the most sort of intuitive flip side to much of the backlash you've heard Katie talk about. So one of the bills we were watching this session that didn't ultimately progress was in Minnesota. It would have narrowed the school-based non-medical vaccine exemption by exempting childcare providers. So an exemption to an exemption, and explicitly authorizing those childcare providers to adopt non-enrollment policies for non-immunized children. We'll see if it comes back in future sessions or even in other states. The Vermont and North Dakota laws relate to mask measures that protected local control. In Vermont, it explicitly granted temporary local authority to adopt indoor mask mandates. And in North Dakota, the bright spot was in the advocacy behind the law that ultimately prohibited state officials from requiring masks, but the bill did not prohibit local officials from doing so. So the bill as introduced would have prohibited both state and local mask mandates, but it was amended to protect local control, and that's a very important win to highlight. Some of the other policies we put into this category include plans to allocate and distribute vaccines to communities hardest hit by the pandemic. There were also expanded coverage of routine vaccinations for adults enrolled in Medicaid and Medicare under the Federal Inflation Reduction Act that now reaches more people with Medicaid expansion in the various states. We've also included examples of social and economic supports that address important upstream determinants of health and facilitated more people's ability to comply with public health orders and requirements. Think things like eviction moratoria and paid sick leave, for example. Finally, I've also included the forthcoming prevention measures law assessment tool, which encourages a cross-sector systematic way to assess the sufficiency of legal authority to implement communicable disease prevention measures in outbreaks. So it provides the opportunity for health departments to bring a variety of stakeholders to the table to reflect together on implementation, compliance, and enforcement issues, as well as the health equity impacts of the various measures. So next slide, please. We've named a separate health equity category, but we have also intentionally tried to identify equitable laws and policies in all the other areas as well, since the goal is really to ensure equity is valued throughout the system and not just a separate box that gets checked. So the policies in this category, the separate category, represent unique opportunities that we think could move us beyond just getting back to business as usual, since business as usual has led to persistent inequities. These first examples are declarations of racism as a public health crisis, which really propose, and in the case of Milwaukee, legally require whole of government reforms to more intentionally disrupt institutional barriers that keep us from advancing racial equity. I've also highlighted the state of Connecticut's law, which identifies a clear and measurable goal of at least a 70% reduction in racial disparities across a variety of sectors that impact the social determinants of health. We also examined COVID health equity task forces at the state level, which laid important groundwork for building on community-driven guiding principles and an influx of funding for community programming and priorities. One important note here in this category is that we did not examine tribal laws or policies. We know tribal nations have exercised their sovereignty in many ways that mitigated the effects of the pandemic and continue to support the health of their citizens and their neighboring non-Indigenous communities. Some of our Act for Public Health organizations, including the Public Health Law Center, are also doing great work to raise awareness about the power of tribal public health authority in partnership with Native serving organizations. So if you're interested in that particular area, please feel free to reach out to them or to us and we can get you connected. Next slide, please. So next up is infrastructure and workforce. For infrastructure, we focused on data modernization, including of public health laboratories where a lot of data is generated, as well as data and IT systems, including the ability to collect, protect, and disseminate data that is disaggregated for the purpose of advancing equitable policies. We know of 5 states and 2 large cities that have received a combined total of $175 million to build new labs or make renovations. And the CDC-led Data Modernization Initiative has been working to use over 1.3 billion, yes, that's with a B, billion, in federal funds to modernize the public health data environment across the country. We also identify examples of laws related to state emergency stockpiles, and for workforce, state and local use of federal funds for hazard or hero pay during the pandemic. We are also keeping an eye on the state and local CDC infrastructure grantees that were awarded funds just in the last few months for workforce capacity, recruitment, and retention efforts to see what exciting things come out of that. We have also highlighted in the report a number of programs that are working to build legal capacity in the public health field as well. The one specific piece of state legislation I have on this slide is the codification of community health worker services as a covered Medicaid benefit in California, which will hopefully help to sustain the influx of federal funding for community health workers that helped increase vaccination rates as well as a host of other measures. But that funding is coming to an end. So the codification of this benefit is huge in California. Next slide, please. Okay, so the two last categories for you before we get into the discussion and Q&A for governance and funding. Many of the examples I've highlighted are on the slide here are state initiatives that have important local implications. And so what do I mean by that? The efforts in Indiana and Oregon have been years-long efforts to modernize the delivery of public health in those states, including in Indiana, defining foundational public health services and updating local public health governance infrastructure and increasing funding as well. The pandemic sort of provided a great opportunity for Indiana to realize the need they had to really modernize. And so a commission formed in 2021 and recommendations came out of that commission that led to legislation being introduced and enacted this year. So that's really great. In Oregon, they've also made a very intentional decision about the importance of collaborating with community stakeholders, providing millions in funding to nearly 200 community-based organizations through a braided funding approach in 8 areas, including health education, mass vaccination, climate planning, and commercial tobacco control. This has facilitated necessary conversations between local health departments and the communities they serve and sort of help to de-silo the funding that can often be so siloed. There have also been impressive efforts in Colorado to repeal state preemption of local firearms and minimum wage requirements, which paved the way for local public health to get more involved on those issues. And we've also seen locals get creative in navigating challenging new legal environments where rollbacks to public health authority were enacted. Montana has actually created a set of tools to help locals understand the changes to their laws and think about ways that they can continue the important work they were doing based on some of the new changes in their state law. A number of states have also adopted laws requiring racial equity into the state legislative or racial equity impact assessments, which are designed to sort of bake racial equity into the state legislative and policymaking process. And then I've already mentioned one example of a shift toward equitable engagement compensation programs in Oregon. So next slide, please. That's just a quick overview of the innovations we've collected, which by no means captures everything you all are doing to improve the public's health, nor can we really tell you what you should be working on because there are so many factors that impact that decision. These are just some of the questions I'd love to hear answers to from all of you that basically get at what did we miss in our examples and our approach. We'd love to continue the conversation with you all. And with that, I will hand it back over to Sabrina.
I will just start with the questions that we have already. I think Katie, anyone is welcome to answer. I think this came in during your presentation, Katie. So I'll start with you, but I think the question is about like how comparable were states, and I think it means across states, but were states public health authority before COVID? If there were differences, how comparable is the legislation they're tracking? So if you want to take a pass at that, and then anyone else that wants to jump in.
Yeah, sounds good. So I'm not sure is the short answer. I think that's not something, so our tracking didn't start until after COVID-19. So I think that is a really good question and would be really interesting to see, but that's not something that our tracking captured. I am going to, though, just throw one link in the chat. There is a data set that some folks created that was before COVID-19. It's captures emergency suspension powers. So it just basically captures whether the governor has the ability to suspend a law or amend or create a new law during an emergency. So playing around with that a bit might be a good resource. So I will put that in the chat now. And then I don't know if anyone else has any thoughts on that.
I can chime in. I can and say, you know, part of the reason the network has a regional structure to provide legal technical assistance is because the structure of public health authorities in the states is pretty different from state to state. There are similarities, right? But statutes are written really different in different states. And, you know, there are some overarching commonalities about whether, you know, a public health system is centralized or decentralized, but even within the most common decentralized structure, again, the statutes are pretty wildly different. So I don't think there's a great sort of, you know, broad strokes answer to if they were comparable. They were in some ways, not in others, and exactly how they are comparable or not is kind of hard to disentangle, quite frankly, because it's constantly a moving target.
Thanks, Katie and Darlene. I think the other thing that I would add is that even when the statutory language is exactly the same, the way it's interpreted on the ground can vary and can depend on the political context, the funding, on the council that's advising the health department, and sort of how liberally or not they're construing certain words or grants of authority. So I'd imagine that there's variation that appears even in the context of identical statutory language in terms of how that's exercised. Wendy, anything you want to add to that question, or I will toss another question to you about I think this came in during your presentation around the term or the phrase principally entrusted. And I think this question about where in the Constitution does it say that?
It doesn't say that in the Constitution. That is actually the Chief Justice's paraphrasing of Jacobson versus Massachusetts, again with the 1905 case. So, you know, the Constitution doesn't say that public health is principally entrusted to public officials, but that has been the assumption and the norm that courts have followed. The Constitution also does not say, to be clear, that courts should limit public health powers or that courts should rebuke public health powers, or the Constitution doesn't even mention judicial review. So these are traditions that have developed and have been held in case law and over the centuries, and there are good reasons to believe that these make sense, right? I mean, you know, if we are a democracy, then people who are elected and represent the will of voters should be the ones, at least at some high level, of making health policy rather than unelected judges. And that's, you know, that's the cheap way of explaining the justification for it. But certainly judges are not health experts. And again, for hundreds of years, judges have accepted that. And what we're seeing now is sort of a change in how judges look at their relationship, their reviewing powers to public health authorities. But it's certainly true that that phrase is not in the Constitution.
Thanks, Wendy. There are two more questions I'm going to get to and continue to encourage folks to put questions in the chat or in the Q&A. But before I do that, because we'll come to an end when we're done with the Q&A, I also wanted to put out to those of you that are still with us here that there may be opportunities in the context of this space, this Dialogue for Health space, to do some more in-depth or interactive chatting about this topic. And so if you have thoughts on sort of whether or not a more workshop type format discussing this with some of us and some of our colleagues might be helpful for you all, and what kinds of issues you'd like to dive into more in this space. Today we gave a really high level overview of trends and sort of where things are going and what we've seen happen, but there's a lot more that we could unpack in a sort of more interactive format. So I'm just open invitation to drop anything in the chat around that piece. The other thing I will say, and again, I'll come back to questions in just a second, is that as Darlene mentioned, but just to like put a next steps fine point on it, as you saw and heard from my colleagues, so the nature of some of what's happening in the legislatures and the courts is changing a little bit. There's not as, even though everyone I know seems to have COVID, theoretically, there's not as an acute emergency happening anymore around us in terms of the pandemic. So, there's a little bit of a shift in what's happening in courts maybe, but in the legislature and the courts to sort of a higher level, thinking about longer term issues in this space, and consequently and accordingly, the work that we are doing at Act for Public Health has also shifted a little bit to think a little bit higher level, less in terms of emergency response to the specific pandemic at hand that was happening the last couple of years, and more towards bigger picture trends, and also what do we want this system to look like moving forward? And we public health lawyers are not the ones to sort of re-envision the whole public health system, but thinking through what laws could underpin a public health system that really works for everybody. And, the fact that all these changes have happened, and that we have been tracking them and thinking through their negative impacts and their positive impacts sometimes doesn't necessarily mean that what existed before COVID was working for everybody. So there's sort of a point here at which we can collectively reconsider what might work. And we are not alone in that effort, but we are thinking through the really legal pieces of that. So stay tuned on that piece. Back to the questions. There is one question about resources around the Public Health Service Act at the federal level. I will say our work has, aside from the federal courts, has been primarily focused on state and local legislative changes, but putting out to my colleagues if you all know of any resources on that.
I do not. I know the network has, we have some citations to the Public Health Service Act, obviously when it impacts a specific issue, but I can't think of a particular resource that's dedicated to the act itself. And maybe, another set of questions and conversation about what you're particularly interested in terms of what about the Public Health Service Act and maybe its impact on state and local level or something like that would be helpful if whoever asked that question wanted to provide some elaboration.
Yeah, I was also going to invite offline follow-up. This is, we do, like I said, have capacity to provide some technical assistance. So if there are specific questions you have, we could potentially point you in more specific directions or do some research. Yeah, Wendy.
Yeah, I mean, I don't know which provisions or parts. It's obviously a big bill, big act. But I should say that in some of the work we've been doing around the litigation, we've certainly looked at the federal litigation about actions taken, for example, by CDC under the Public Health Service Act. So the CDC's eviction moratorium that I discussed was taken under that act. The mask mandate was under that act. So I don't know if you're looking at CDC's authority under the act. I don't know. I mean, there's a lot of different provisions in that act. So, happy to also take more questions or connect offline.
Thanks, Wendy. So the other question I see in the chat is around the overlap between public health impacts of COVID and climate change, and the need for greater public health preparedness for climate change. So I think there's a question about tracking specifically, but then would also invite folks to talk more generally about thinking and connecting dots in those spaces. So the tracking question, I think maybe Katie, I don't think we are tracking that specifically, though it might be something we would want to consider tracking as we're moving forward in this project, but I'll kick that piece to you and then.
Yeah, I think that's right. So we are not currently tracking provisions specifically related to climate change, but agreed that that's, going forward, that's definitely something we could consider, with the connection there. I think that, that's something we could give some thought to. So yeah, thank you for raising that.
The only thing I'll add is more to come, as Katie suggested. I mentioned Jill Krieger, my colleague here at the network. This is one of the areas she really is doing a lot of thinking on. And I believe she's actually working on a piece right now to sort of make some connections between how public health authority is being used, isn't being used, could be used in that space. And it's obvious implications for equitable outcomes and equitable process as well. So I'm sure once those resources get finished or added to our Act Public Health work, if you sign up on our email list, you'll get notifications of that.
And I'll just add again that the major questions doctrine, which I talked about at the sort of litigation level, which really, although there are some pre-COVID roots, was really adopted, embraced by the courts in a full way in public health authorities cases. We certainly have seen, and we've written about how it has bled over and is now significantly challenging the authority of federal agencies to deal with climate change. So there is certainly spillover in that area. That's really quite important.
Yeah, thank you. I know ChangeLab also has a project that's a little bit separate from this about the health impacts of climate change, and your questions actually spurring me to do a little bit more connecting dots across these two projects specifically. So thank you for that. Okay, I think we probably have time quickly for one more. We're almost at the end here, but there's a question which I appreciate the offer to also take it as rhetorical about data collection. And I know that has been, came up a little bit in the bright spots. It also has been a problem. It's something ChangeLab, again, in some other contexts, has been doing a lot of work on. And so, yes, it has come up, but let me invite any of you to also just weigh in on anything data related you would like to say, if anything.
I think what I'll just say, right, is there's a lot of conflicting, I think, tensions in that space, right? And the law can be complicated, more so than it needs to be, or there are perceived barriers, which again, this person who asked the question seems to already know all of these things. So I'm not saying things that this person doesn't know. But it is, I think, one of the areas we've got to figure out how to talk about in a way that isn't so complicated, because that sort of excuse, I guess I would say, makes it really hard to make progress in that area, right? So I think that's one thing that hopefully the CDC-led data modernization initiative is going to help with, right? As well as with everybody else, all the other partners who are thinking about this as well. So again, another sort of stay tuned and see what happens here sort of thing.
Thanks, Darlene. So I think we're just about at time. I think, Casey, hand it back to you to send us all on our way. I want to thank everyone for your time today, and for my fellow panelists for your time and preparation for this as well. And again, just reiterate that we would love to hear from you all. So please reach out with questions, feedback, thoughts. Take a look at the website for resources, and stay tuned for the further evolution of this work. Thanks.
Thank you so much to all of our panelists for that great presentation. And thank you to all of you for joining us today. We hope you enjoyed this web forum. Please take our quick anonymous survey, the link of which is in the chat, and you'll see it after the event as well, to let us know how we did today. And please let us know what you think, and if there's any topics you would like to see us delve into deeper. Have a great rest of your day.